So I'll just introduce Dr. Miller before I hand it off to her. So Dr. Linda Miller is CEO and a certified occupational therapist ergonomist at EWI Works International Inc. in Edmonton, Alberta, Canada. Linda established EWI Works in 1991 with the goal to provide education and consulting services to employers to prevent workplace injury and improve employee performance. In the early years, the focus was on in-person training and consulting, very similar to CCSA prior to COVID. But in the past 5 years, the corporation has been expanding into software tools to manage training, coaching, and telehealth support. Her industry experience, and especially in healthcare, allows her to support individuals to find solutions that work to minimize musculoskeletal discomfort and injury. For 3 decades, Linda has presented at health and safety conferences and teaches regularly at the University of Alberta, where she holds an appointment at the Faculty of Medicine in the Division of Preventative Maintenance and the Faculty of Rehabilitation Medicine in the Department of Occupational Therapy. Very excited to have Dr. Miller join us today, and I'll hand it off to you, Dr. Miller.
Thank you very much for having me, first of all. And it's nice to be able to actually talk on this particular topic. I'm going to be keeping it quite high level today. I'm going to talk really about the components of a musculoskeletal program, and then also talk about some advances that we're starting to see in terms of different types of interventions that are being put into place to help manage musculoskeletal injury. So today, what I want to actually cover through this is I'm going to go into a very brief overview about the scope of MSIs in industry, and very specifically around your industry group being long-term care and then also continuing care. Talk about the risks, because we do know that there's specific risks that we actually look for in the workplace. We're going to then go into some of the impact of MSI specifically for your groups, and then start to think about what really does make up a really strong MSI program, and then also touch on some trends in industry right now. And then I'm going to leave some time at the end for questions and answers as well. So just to give you a little bit of my own background, where I started with musculoskeletal injury, I was an occupational therapist for a period of time, but I got very interested in injury prevention. So I've done quite a bit of work with the health authorities here in Alberta, as well as we've done a lot of work in the not so distant past with surgeons, really looking at how do we actually start to manage MSIs and reduce the risk as well. So we've had lots of exposure, or myself specifically, around training programs, MSI prevention programs, but also looking at good quality controls that can be brought into place in order to actually start to address the high number of MSIs in the workplace. So I always like to start with a good working definition, because there's a lot of times where we talk to people and they'll think MSI is actually the injury, but it's actually a category. And when we talk about musculoskeletal injuries, we're really looking at the whole musculoskeletal system, where it can affect muscles, nerves, bones, tendons, ligaments, cartilage, or spinal discs. So it's a very, very broad group that we're often looking at under that category. The other thing that's really important is that we often see a group of injuries that tend to develop gradually over time, where we can also have injuries that can be related to a very specific event. And so when we see that one that's specific to the event, where somebody might have had a slip or a fall or had overreached, it's quite easy to actually see why the individual had the MSI as a result to the exposure. But the ones that tend to be a little bit more challenging, I definitely know that this is the case in healthcare, are those like gradually occur over time. And that often comes from the fact that we have these repeated exposures to awkward postures, high forces. We might have to sustain a posture for extended periods of time, and slowly it starts to affect the tissues. And sometimes those tissues will recover because of rest and recovery. But over time, if we don't have the proper rest and recovery and we keep taxing those tissues, we will start to see the onset of MSI, such as sprain or strain or tendonitis. We'll start to see that develop gradually over time. Now, I was able to actually take some data that was sent to me from Leanne and actually was able to look at what's actually going on in terms of lost time claims and really what is the impact of MSIs on your industry. And this actually looked back from 2017 to date for both senior supported living and continuing care facilities. And it is a significant number. We're looking about 40% of all lost time claims are related to sprains and strains. So it's the biggest category, and it has a significant impact in terms of lost time days, restricted days or modified duty, and then definitely in terms of overall cost. And even I would beg to start to bring up that it even might be the cause sometimes for people to leave the profession early as well. Now, interesting enough, if I look at most industries, we will see a pattern based on the nature of the exposures that individuals have. And in long-term care, the vast majority of sprains or strains are actually involving the back or the trunk. So that's very much what we would expect to see, because there's a lot of manual handling, but there's also a lot of resident interaction as well and resident handling. So if you look at other industries, we'll often see back. Back seems to be the most dominant in the province and across Canada, but sometimes we'll see more shoulders, or we'll see more of a lower extremity injury. But again, in those particular industries, the nature of the exposures are different. So a lot of awkward postures that we'll often see in your industry, higher forces, and sometimes people can start to experience the potential risk for an incident. Now, again, from your data, and it's always good to look at data, is that when we're looking at the average cost, so we know that there's some that are going to be much more expensive and others that are not going to be as expensive, but the average cost of a sprain or strain is running anywhere from about $5,500 to $4,900. And that's just the direct costs. And I think that's really important, because that's only talking about part of the picture. And interesting enough, when you actually dive a little bit further into those stats, we start to see that the leading cause for sprains and strains are really overexertions and bodily reaction and exertion. So very much what we would expect because of the exposures that individuals may have in the workplace. Now, if we go a little bit further, and remember this is from 2017 till to date, is that we have a fairly significant amount of direct costs that are actually going to MSIs. So for continuing care, about 14 million plus, and for senior supported living, about 6 million. So it's a significant amount of money that's actually being spent on direct costs related to sprains and strains. But like I said, that only tells us part of the picture. And when we start to think about the indirect costs, now we're starting to look at anywhere from 5 to 7 times those direct costs. And it comes in the form of often having to get new people in, having new people trained. Others might have to work more overtime. We may have longer shifts. We might have to, it might also impact us in terms of the time and the number of people that may be leaving the profession. So there's a lot of indirect costs that have to be factored into the overall scope of how much the sprains and strains are actually impacting the industry. So I want to go over a little bit of a model that is very well accepted right now in the whole view of musculoskeletal injury and sprains and strains, and kind of start to think about what are some of the reasons that we are seeing these injuries develop. Well, I'm not going to be surprising most of you that there are definitely biomechanical risk factors, and I'll talk a little bit about those and just very briefly touch on them. But we also now know that there are organizational risk factors that actually can contribute and either modify it or actually enhance or amplify those biomechanical risk factors. And then we also know that there are definitely personal risk factors as well. And so we want to really be open to the fact that there are those physical risk factors or biomechanical risk factors, but then there are also modifiers that can impact if an individual will be more susceptible to an MSI and if they potentially will develop it over time. So when we deep dive and we start to think about those physical or what we call those biomechanical risk factors, There's actually 7 risk factors, but the most dominant ones that we see in healthcare are really exposures to very high forces. We see exposures to very awkward postures, and that's often with the shoulders or the back, even the lower extremities. And then we'll often see the fact that people are repeatedly exposed to this and for longer durations of time. And so it's not the one risk factor that we're typically focused on, it's how they tend to come together. And so that's why we often talk about, is there a way to improve posture? Is there a way to cut the repetition rate? Is there a way to reduce the impact of the force? Because we're really looking at how those risk factors start to come together. Now, interesting enough, 2004, ISO actually looked at some of the other factors that can actually contribute to increased risk for developing MSIs in the workplace. And I can't talk to each of your workplaces, but it might be worthwhile to just think about if any of these things tend to make up any of your environments. The first one that they actually highlighted really was that when people are exposed to frequent or very long shifts or overtime work, there is that heightened increase for potential risk for MSIs. And interesting, this morning, I actually was talking to a group down in the US, and they were actually considered essential during COVID. And they saw their MSIs go up quite quickly because there was a lot of coverage that had to happen with people reporting in sick. And so we did have that characterizing lots of workplaces during COVID and still now today. The other one that has been brought up as well from ISO is when we have shifts that are longer than 8 hours. And I always like to highlight for people when we actually pull from guidelines, those guidelines, when they're looking at forces and repetitions that people should be looking at in terms of overall limits, they're based on an 8-hour workday, not a 10, 12, or 14-hour day. So we do know that when people are working longer shifts, the potential risk for fatigue and potential risk for developing an MSI can also put them at greater risk. Another one that does definitely pop up, and I don't think this would surprise anyone, is having insufficient rest breaks or even days off. And one of the things that we've seen with lots of workplaces, and I don't want to talk to any of yours specifically, but lots of people had multiple jobs, and sometimes they didn't always have the rest breaks that they need, or they were called into work to actually cover off other people that may have been out or away from the workplace. So again, that's another one that has emerged as an organizational risk factor. Another one as well is productivity requirements. So if we find that they're not even between workers, or if they actually fluctuate over the course of their shifts, or even at different times of the year or month, again, this can be considered another modifier that can increase our risk. This is one that a lot of times we don't often think about, and I talked to a lot of people about this, is around this whole idea of rest. Because if we can give the body rest and recovery, that's part of the equation that we can actually help the tissues be healthy and to heal. But if we have individuals where they have less than 11 hours between shifts, and when I talk about that is that a lot of times people don't factor in their travel time. It's often hard to get good restful sleep, and they often are functioning on much fewer hours between their shifts. So that can be another risk factor that can increase our risk. And then no surprise, work culture is definitely one that is considered an organizational risk factor. And I always see how a lot of times how work culture can start to influence this, because people might have access to equipment, but if they're not encouraged to do it, or if people don't see it as a benefit to use it, that can actually impact how people approach a job. And if they have a control and not use it effectively, that can be a problem. Another piece of that is also the maintenance of equipment. And so we give people carts, or we give people access to lifts or any type of other equipment that can be used in the workplace. The maintenance piece is extremely important. So making sure it's reported if it's not functioning properly, and then making sure that it's actually maintained so it can be effectively used. And this last one, I remember this a lot from my experience with working in healthcare, is availability of equipment. And so if it's hard to actually access the equipment, and it's going to create a lot of extra effort to go get it, it's often not uncommon for people to bypass it as well. Now, the final area, so we talked about some of the biomechanical risks, we talked about some of the organizational risks, but it's important that we also keep in mind some of the personal risk factors as well. And when we look at the personal risk factors, we do know that size and stature definitely impact an individual's fit in the workplace, how they might actually interact with their environment. So that is considered one of those risk factors. So if we have somebody that's really tall or somebody that's very small in stature, and they don't fit with the actual design of the work area or even the flexibility of the equipment, then they may be working in much more awkward postures and placing themselves a little bit more at risk. The other one that we want to keep in mind is also general health and fitness. And there is a fallacy out there. I am a very healthy person in the sense of being physically fit. I love to cycle and I love to run and be very active. But just because somebody's physically fit doesn't mean that they can take on more and remains healthy and safe in the work environment. General health and fitness are extremely important, but they should never be used as a strategy to bypass good equipment or proper education and training. The other one that we always like to refer to as well as personal risk factors are age and gender. And in terms of the female population, we are at sometimes in our lives at greater risk for developing an MSI, and the one that's most dominant is during pregnancy. We will see that the body does change with as we move through the pregnancy. We get more lax ligaments, and there's more stress being placed on the back as well. Age, the biggest thing with age, and there was a real fallacy for a long time that as we had aging workers, we'd see this massive rise in MSIs. We haven't seen that, but what we have seen is that as we start to age, we don't recover as quickly. And sometimes we do have more permanent modifications or accommodations that have to be taken into place as well. Experience and training are absolutely fundamental to the picture, that having adequate training and the experience of knowing how to approach your work, organize your work, work with others certainly has a significant impact in terms of potential amplification or modification of some of these biomechanical risk factors. Fatigue levels, if people are working fatigue both at a local muscular level, but also that whole body level, that can actually put them at greater risk for a potential MSI. And one of the biggest predictors is actually previous injury. So if somebody's had a back injury in the past, it's one of the greatest predictors of future injury going forward as well. So we do know that there are those biomechanical risk factors, and I'm going to talk about how important we need to go out and actually identify them. But we also want to be aware of those organizational modifiers, and then also the fact that there will be some personal risk factors that people bring to the table as well. So I want to talk, and I know this slide looks quite busy, but I really want to talk about the fact that when we approach MSI prevention, we really have to look at all the fundamental pieces that have to be incorporated in an MSI prevention program. The first thing I always tell people, it's really important to understand your data. So if you've had any incidents in the past, or if you can talk with your industry as a whole, having a good solid understanding of the data really helps us to understand where incidents are happening, what type of MSIs they are, and potentially allows us to start to focus on where we should actually tackle our program in terms of development, and then also start to think about designing controls in order to mitigate some of those risks. Once we have a good understanding of the data, and that's something we need to do on a regular basis, is revisit it. Most people do that on a quarterly basis or on a yearly basis as a whole industry group. We need to really start to think about the job demands. And I often recommend, if you haven't, go out and try to do some job demands analysis for your facilities, because not only will they help with return to work of an injured employee and its request for the WCB, but it also helps to start to identify what jobs and specifically tasks are most physically demanding and psychologically demanding in terms of people's work exposure. So it really helps us to on a rehabilitation side, but it also helps to highlight where we might want to start to focus when we go in to do our evaluations. I always talk about evaluation as the next piece, and very much it's no different than any other safety activity. It should be part and included as part of your inspections. If you have an incident, to actually do the full incident investigation so you can get at the root cause and then actually be able to put in controls to prevent it in the future. And in some cases, you may actually benefit from having an ergonomic analysis done. So there are times that you can look at those levels, and ideally your MSI prevention program should include that evaluation piece. Once you've done the evaluation, you've got to the level of those root causes, really identifying those feasible controls. And I'm going to go into a little bit about controls. But the controls are, people often say to me, we've done so much ergonomics. And then when you ask them if they'd actually implement the controls, a lot of times people will say, oh no, we didn't, we did the analysis. Well, that's not going to give you the advantage of getting a handle on your MSIs. So identification of feasible controls and really start to look at what is actually effective to bring into the workplace. I know there's been lots done on education and training. Education is a fundamental piece of the puzzle. And it's certainly, I'm going to touch on some of the things that have been done to date around education and training, but understanding what the MSI risks are, what are signs and symptoms, the importance of early reporting, how to use the body effectively, and also your equipment really are fundamental. And it's a requirement also under the code as well. Medical management, it's really important for those that have good functioning MSI programs or prevention programs in place. People are reporting early signs and symptoms, because if I can report early signs and symptoms, I can go out and investigate why that person might be experiencing those signs and symptoms and put a control in early before we actually have an MSI incident that takes place or a claim. The other part of that is also around the medical management when people have to come back on modified work, specifically after a musculoskeletal injury. And then the one that I always try to reinforce with people, and it's one of the most important pieces of the puzzle, is having employee participation and having employees participate through the entire process or in each of these components as part of the evaluation, part of the identification of potential controls, because a lot of times being not directly involved in the work site, we can come up with very sometimes expensive controls when your frontline employees might know of something that may be lower cost and much more effective. And it might even be just even how work is reorganized or procedure is done. So that employee participation is fundamental from the evaluations piece, the identification of controls, and then to provide feedback if the controls are actually working. So having them actively involved really gets a very robust program when we start to go forward. And the one that I really encourage people to do is share your success stories. So you have your industry association here, and if you can, as you have successes, be able to share them, because we each can learn from one another. And this is becoming really quite apparent in a lot of very high performing companies right now, is that they want to learn from events and incidents, but they also want to share the success of how they were able to control it as well. So having that is a fundamental piece of the puzzle. As I said, it's very much like what you do in safety. And I really highlight for people that you really want to go out and do your worksite inspections. A lot of times you're going to be able to identify the problem quickly and be able to come up with control. Other times you might have to go in a little bit more in-depth evaluation. And that's why having sometimes employees trained I often talk about having an MSI prevention team or an ergonomics team. Then you can go in a little bit further and analyze the potential concern. And then sometimes you may need a more in-depth ergonomic assessment. But I certainly don't ever see that everything has to be done by an ergonomist. There are times when you might need it, but there's a lot of very effective things that we can incorporate in worksite inspection, and then our basic evaluations in the worksite. Now I want to get into controls, and a lot of times we think about all the different controls that are actually in place, and I'm sure you've seen something very similar to this related to safety. But the interesting thing is there's lots of focus often on PPE. I know that a lot of times in healthcare, there's a lot of focus on training procedures and even becoming aware of the hazards. But really, we want to keep pushing towards if there's ways to control the hazard or even eliminate it, because it's no different than your safety. We have the same approach to actually tackling MSI risk factors and hazards as well. Now, one of the things that was done, and I thought this was a very effective study that was done, it was back in 2008, but it still stands very true to today, because they looked at over 200 different studies that actually implemented controls to manage MSIs. And what was really interesting, and I'm not saying any one of these is more important than the other, but when we only rely on training and we really are hoping for behavior change, what they saw from these studies where we only use training and education, we saw only about a 10 to 20% level of effectiveness. Now, do we need training and education? Absolutely. It's a fundamental piece of the MSI program. But if we only look at behavior change, it's not uncommon for people to be fatigued. If they're in a rush, they may bypass proper body mechanics or even some controls. So we really want to keep pushing in to other levels of controls as well. So we can certainly start with the behavior changes. Other ways that we can intervene might be to actually look at breaking up the duration of exposure to the hazard. And that's where we often talk about job or task rotation. That can be fairly effective as well. But I really want to highlight that for it to be effective, you need to be rotating to something completely different in terms of the physical demands. So just to move down to another room may not truly be a break in physical demands. So if we're going to be using job rotation or task rotation, we really do need to look at, is it actually changing the demand on the part of the body that's being exposed? The next areas that I really see where we see more effective controls of a lot of our hazards is really reducing sometimes the level. And that can be with introduction of carts or pallet jacks if we're going to be working with manual handling, using adjustable equipment. And if I think about resident handling, actually adjusting beds, adjusting positioning, all of that will help to improve posture. And interesting enough, it also helps to reduce the overall forces. So that now we're starting to get some more effective intervention. And I'm not saying that one or the other's more or less, they all work together, but we start to get better control of the hazard. And then the last one is really looking at seeing if you can eliminate the exposure as well. And when I look in some of the environments that I've been in the past, we certainly are seeing more resident lifts actually being installed. And as long as they're used effectively, and that gets back to our training and education, is that then we can start to see that whole set of controls start to work really effective. So I want you to take away from this that it's a number of controls that will help to actually control the MSI risk. It doesn't mean leave training and education. That's absolutely fundamental, but it's also to keep exploring other forms of intervention as well, such as introduction of equipment, or even looking at optimizing how that equipment is actually utilized as well. Now, I want to talk a little bit about some of the trends that we are seeing in industry. This was actually something that had to take place over COVID, and we are involved with the Continuing Care Association, and we are starting to see more and more people use remote education tools. and even coaching. And this is becoming quite popular, and it's not just for your organizations. I'll highlight, I do a lot of work with surgeons. We're actually doing a lot of remote coaching for surgeons as well, because of the fact that they have to leave the profession often in their early 50s. And so having that remote coaching and education becomes actually quite critical to helping reduce some of that impact. So I want to show you a little bit of what we were able to work with your organization. And it actually is a motion capture control system that people can take a video and then they can actually overlay, and it's using the RULA, which is an analysis tool, or the REBA. And it starts to highlight where that person has increased risk and where they're at very high risk for awkward postures. Now, I don't use that as my analysis tool as all encompassing. What I do is utilize that to start to talk to a frontline employee to be able to show them how to improve that. And I can actually take a video of them when they're doing it the first way. And then when we provide some suggestions, or your group provides suggestions, they can actually see the impact, and it's very clear. So we're seeing this remote coaching, utilizing a lot of these motion capture tools being included across multiple industries right now. The other one that you will see coming up very quickly, and we're actually involved in 2 major studies at the University of Alberta right now, is the use of external, what we call exoskeletons. And this is gaining a lot of traction right now. We actually were able to get a very large grant with engineering, where we're actually looking at it in the use in construction. And we will see exoskeletons come across industry, I would say, within the next 5 to 10 years. And it will be very much part of what, and the big debate right now is it truly PPE or is it engineering control? But it's something that is emerging. And a lot of the discussion around exoskeletons is that within 10 years, we'll see them on the shelves of Home Depot, and the general public will be utilizing that. So this is something that's taking a lot of, it's becoming very interesting right now. And most of the exoskeletons that we're actually working with, and most industry partners are working with, are ones that are not power-based. They're actually very manual-based with levers. And so they don't add a lot of extra weight to the person. They don't need to have any special charging. They're just a series of levers that actually a person fits to their body and then can utilize it to perform either a lift. This one's for the back, but we have ones that are for the shoulders for high work, or even if people have to do very low work, there's some for the legs so that a person can crouch and still be supported. So this is another thing that I really believe is going to emerge in the industry, is you're going to see the introduction of exoskeletons as well. One of the challenge though, and I think this is something that should be considered, and this is a personal risk factor, is that when we've been doing our studies, even just with our small group, anybody that's very small in stature actually don't fit very well for exoskeletons. So I think that's an interesting piece if we ever look at this in continuing care, is you have a lot of smaller, petite people. And so that's going to have to be an evolution with the exoskeletons if we want to actually have that as an effective intervention. Now, the other thing that we're seeing a lot of, and there's a lot of interest in this around looking at job matching and early intervention. And we don't do pre-hire screening, but we can often look at post-hire screening. And I'm not a big proponent of screening people and finding only the right person to fit the physical demands. But what we often will see, if we can actually watch people over time, we can catch if they are starting to have problems. We can get them in for early intervention. And a lot of times it might be a strengthening program. It might be something that we want to look at getting a little bit of rehab, but we're trying to get in early so it doesn't become a lost time claim. But in order for that to be done, we really do have to understand what the job demands are, and then really start to look at what that matches with that worker's capability. And the biggest thing that I see, the biggest opportunity here is that it's going to allow us to get in at a more of an early intervention space. I don't see it as something to eliminate workers. That's not the goal whatsoever, but it may help us to start to be much more aware of people's capabilities, how we can actually work on some of their activities for strengthening. But also, if we have a lot of people not meeting the requirements, it might really focus us on how we're going to have to control those hazards. So I see this as another area that's emerging. Interesting enough, there's a very big study going on, and it's just being published now with paramedics. And again, they're looking at some of these models because not everything can be controlled. But my goal is that we control what we can, and then we continue to keep trying to improve the work situation as well. So I know that it was a quick talk, but I'm going to open it up for any questions or comments, and just hopefully you've got a sense of really what we need when we're starting to look at a full MSI prevention program.
Thank you, Dr. Miller. That was a really interesting presentation. Lots of possibilities on the horizon, that's for sure. Have you, similar to the exoskeletons, have you heard of any of those clip and go technology as a way to,
are they postural called
solder?
Are they wearables?
Yeah.
Yeah, the biggest thing with the wearables that I find, and some of it can be helpful if the environment has been designed to help, like to maximize body posture, they can be effective. But one of the things that we find is if the environment hasn't been tackled, it's very frustrating for the frontline employee, because what they come back with is they'll say, you know, I'm being told I'm doing it incorrectly and I'm in really awkward postures, but there's no way to elevate the patient, or there's no way to elevate the product. So I really think it has to be matched with having good workplace design. And then, yes, they can be very beneficial.
Yeah, great comment.
Yeah.
I see one question in the comment box. Where can you purchase Investigate exoskeleton wearables?
Well, they're not cheap right now. They're looking, we're very fortunate. We're part of a huge grant. Actually, I have to brag about this for a second, because a lot of the funding came from Alberta Innovates and also NSERC. And right now we're part of a bigger group out of the university looking at it for construction. So it's very interesting. They see the need, because it's often very awkward postures in the environments they're at. And you know, I think watch what's going to be coming out of the University of Alberta, and it's in our own backyard. It's actually quite exciting. The average, just to give you an idea of what the exoskeletons cost right now, we're looking at the average one about 5,000, and it's just because they are still very new. My biggest caveat on the whole thing is they need to be introduced in a very purposeful way. And it's part of the problem. What we see is people will introduce them, but they haven't really thought about how to properly fit them, which tasks would benefit from them, and really how do people actually get introduced to them so that they are effectively used. So that's one of the pieces that we're working on right now. And I'll give you an idea of what we're looking at them for, is actually the removal of manhole covers. And you can just imagine there's every single environmental factor going on. But when people have to take a manhole cover off, there's very high incidence for shoulder and back. So that's what we're exploring right now. And I think you're going to see this in healthcare in not far off. We're seeing it actually, to just be quite transparent about this, is we're seeing it actually already being used in ORs. So when we have surgeons that are working for long periods of time, they actually have an exoskeleton now for the neck, because there's so many neck issues for surgeons. So.
And Dr. Miller, your comment about or the observation of employees in our industry being smaller or petite, that may not be ideal based on the exoskeletons that are designed today. That's just an interim issue, I assume, that they'll be able to fine tune the adjustment, or fine tune the design.
Yeah, and I think it's because where exoskeletons were primarily introduced, there were two big major groups. One was with rehab, and a lot of exoskeletons were for walking after spinal cord injury. But in industry where they were really introduced was automotives. And so we often had, had some diversity in the population, but the vast majority of the people were bigger individuals that they didn't have to worry so much about fit. So that's really only been in the last 5 years. And we're in the infancy really of where we're at with exoskeletons, but it's really exciting because it might be the first kind of PPE for ergonomics or muscles, sprains and strains. So.
Excellent. I see a question in the chat. Do you suggest job capabilities before hire?
Meaning,
Deborah, do you mean like a physical demands analysis, or can you just clarify in the chat, or feel free to unmute?
Just would they require, would you suggest maybe doing the job capability testing to see just how much they can carry, how long they can carry? I know a lot of companies do have that before they hire.
Yeah, so there is a real movement to incorporate that back in industry, not to replace controls, but it's to actually start to look at people from hire to retirement. And so it's not to eliminate people from the workforce, but it's starting to really understand that we will change over time and with exposures. And when we can actually get in and do some kind of preventative therapy, we might have more opportunity to prevent injury. Now, my only caveat with looking at capabilities is, yes, there are some people that probably are not well fit to certain jobs. And there are systems now that people have rankings, but we always want to see if there's a way that if they can't meet all the capabilities, is there a way to modify the job in some way to actually have them in the workforce? Because we're not, like, I honestly, I'm speaking from my own experience right now, is we don't have a lot of access to employees. We're really in a time where we're in a very competitive time frame. So it's not saying, Deborah, not to do it. It's just, I think we have to be careful that sometimes we might find that we're not going to have enough workers as well. So we want to make sure that we design the work so people can do the work.